Hello, everyone. Welcome back to another episode of the Found My Fitness podcast. I am very excited today. We're going to be talking about COVID-19, and it's a topic that's on all of our minds right now and has been for the last almost a year, pretty much. And my guest today is someone that, in my opinion, has been a real important voice throughout the COVID-19 pandemic. His name is Dr. Roger Seheult, and he is a quadruple board certified physician. He is certified in internal medicine, in critical care medicine, in pulmonary diseases, as well as sleep medicine. But in addition to treating patients and also teaching medical students in a classical setting, like a classroom, he also runs a popular and very, very informative YouTube channel where he educates not only medical students, but the broader public in general. And his YouTube channel is called MedCram Videos. And this is where I discovered Dr. Seheult. He has been covering the COVID-19 pandemic pretty much since the beginning. And he has been someone that has really done a fantastic job diving into the scientific literature, being very comprehensive and covering just a wide array of very important topics related to this pandemic. So I'm very excited to have Roger on the show today and to discuss all things COVID-19. Roger and I share a few passions. In addition to educating the public, we also share passions about, scholarly work and diving into the literature and trying to, answer questions, answer important questions and find good data to, support hypotheses. So, Roger, can you tell us a little bit about, you've been covering COVID-19 since March, 2020, and how have things evolved for you in terms of covering this pandemic? And you and I were chatting actually a little bit on the phone a few days ago, and you were telling me sort of what got you into this, how you were in the trenches out there and decided to sort of dive into the literature for certain reasons. Maybe we could talk a little bit about that.
Yeah, so thanks very much, Dr. Patrick, for having me on the show. So this all started back when I was, I could go far back, but I've always had a passion for teaching and taking things that are complicated and making them easy and understandable. And all through my college, medical school, residency, and now as a assistant professor at a couple of medical schools, that's what I do. And one day I had the honor of having a PA student, a physician assistant student that would change my life. It's not every day that a student changes your life. It's usually a teacher that changes your life. And Kyle Allred was, he's the other half of MedCram. And he happened to be my PA student for a month. And he said, Dr. Seheult, people don't go to the library. Students don't go to the library, check out articles, like, I used to do. They go to YouTube, they go to Google, and they Google the question they have, and they look for the shortest video they can find. And so he saw a real need there, because as they go through the PA program, which is a 2-year program, sometimes they don't get all of the education that they feel that they need to get. They have to do a lot of studying on their own, and it's very time constraining to go and check all of these things out. Long story short is we started making videos about medical topics, so COPD, congestive heart failure, pneumonia, asthma, and we started posting them on our YouTube channel. And we'd gotten up to a few 100,000 subscriptions. We were doing some videos that were very helpful. And then coronavirus hit, and one day we decided to do a coronavirus video. This was probably in late February, early March, and it just exploded, because here was this virus that was basically taking over in China, and people wanted to know about it. People were concerned about it. and people wanted to know more. And so instead of the world looking at movie stars or sports stars, they were now for the first time looking at people like you and me, Rhonda, people who had been working in medicine and nutrition and medicine and science. And really, there was a lack of communication. I mean, we have whole TV shows on sports about how to communicate what's happening in the world of sports, and we have whole infrastructure for that. We don't have that for medicine and science. And so it really put a lot of people like myself and a number of other people like myself and you on the hot seat to describe this to millions and millions of people. What is it that's really going on? And really the question was begged is, what do we do about it? And that's sort of changed our lives.
And what do you like? Do you feel like earlier on, your thoughts about the pandemic have changed since everything that's happened since 8 or 9 months ago, in terms of prevention and treatment and what the data out there suggests? Like how has that evolved for you in terms of, you're also in the hospital treating patients as well?
Yeah, it's, I grew up in the scientific world of, the hierarchy of evidence. So you've got epidemiological evidence, case control studies, but really the thing that you need to have to be able to look a patient in the face and say, this is going to help you, is a randomized controlled trial. And those type of trials take a long time. They take a long time. And the problem in this is that the system that we've set up of randomized controlled trials, applications to the FDA, these are great for diseases and conditions that are with us chronically and that move slowly. But they're not adequately designed to really help the majority of people in a worldwide pandemic, because people are dying very, very quickly. And you want to come up with answers very, very fast. And these things take time. So that's one thing that I learned very, very quickly, is that if you want to try to save lives, and all of us look at this from a different point of view. I guess I'm coming from the point of view of, I understand the ivory towers. I understand the people at the FDA. I understand the people that people are relying on them to say, here's something that we've tested that looks good and it works. But on the other hand, I'm working in the trenches too. So I'm looking family members in the face, and they're looking at me and it's like, what can I do for our loved one? What is going to work? And what we have to do is marry those two concepts together and come up with things, I believe, that may have plausibility to work, but if we're going to institute something, if we're going to do something, it's got to have very, very low risk. And so what you've seen is a wide variety of things now that have gone through the FDA that probably never would have been approved under normal situation. But because of the pandemic and the flexibility that we need to have, we need to move quickly, because as things get out of hand, more and more people are dying. So for instance, convalescent plasma was approved using emergency use authorization through the FDA. There was no controls in that study. So that's just an example of the type of things that we're doing. We're moving quickly here. We're in a pandemic. And we have to be creative, and we have to be understanding that this is not business as usual.
Have you looked back in history to see? I mean, this isn't the first time the world has dealt with a pandemic, and there's always lessons to be learned when looking back in history. Things repeat themselves, right? And you're not always starting, from scratch. Basically, there's a lot you can learn from the past.
Oh, absolutely. I'm hoping we were going to go there in this topic, because there is so much that I have studied. Not to say that I'm an expert in this, but just looking back at where we were just 100 years ago is very informative in that. And I think if we want to get into that, what we've got to do is look at the disease itself. So COVID-19. And I think probably one of the first things that somebody needs to understand when you think about COVID is it's all about timing. It's very important that you understand that there is an early portion of the disease and there's a late portion of the disease. And the timeline that separates those two is really when you get pneumonia. I think that's probably the best way to make that demarcation. Early in the phase of COVID-19, before you have pneumonia, there's a certain set of of factors that are going on in the body. We can get into detail what those are that make certain interventions more plausible and more efficacious. And then there's the later phase of COVID-19 where patients generally are hospitalized, they're on oxygen, and we see other types of interventions to be much more effective. To give you an example of that, steroids. So dexamethasone, that was a UK recovery trial that came out, showed without a doubt that steroids improve. Well, what they found was that patients who were not on oxygen, so in other words, early in the course of the disease, did not benefit from steroids. It was equivocal. Whereas those that were the sickest patients on the ventilator requiring high doses of oxygen seemed to be the ones that benefited the most from dexamethasone or steroids. The flip of that was remdesivir. So whereas steroids were very beneficial late in the course of the disease, medications like remdesivir, which are it's not an anti-inflammatory, but rather an antiviral. It prevents the viral replication. The opposite was found. Remdesivir was much more efficacious early in the course of the disease, and not so much so for those patients on the ventilator. So when you talk, it's not just like this disease is a one-fits-all thing. You've got COVID. No, is it early or late COVID? So taking that into consideration, we can then go back and look and see what people did 100 years ago for these diseases, because what people did in the hospitals 100 years ago is nothing like what we're doing today. I mean, they did not have oxygen. They did not have ventilators. They had some medications, which we can talk about. But what I started to realize is that in a pandemic situation, it's very, very difficult to scale up production of any pharmacological agent, as we're finding out now. Let's look at vaccination. Let's look at medications. Fortunately, dexamethasone is dirt cheap, and we've had it for a long time, and we can manufacture this stuff pretty quickly. But if you find any kind of pharmacological intervention, be it hydroxychloroquine, be it ivermectin, and we can talk about those things have to be scaled so rapidly and to such high degree that as soon as you say this medication is efficacious, you can't find it in the pharmacy. It's gone. And so what this has done as to me as an individual has really looked at plausible, biochemically plausible, rational, efficacious remedies that are not a cure-all, they're not good to fix you or protect you 100%, but may, in a population type of setting, swing things enough so that we can deaden the blow of the pandemic.
And are you talking in a sense about lifestyle factors, things that?
Oh yeah, absolutely. Fruit? Absolutely. So lifestyle factors, but not just lifestyle factors, because what are you going to do if somebody who has not been practicing the proper lifestyle and now they get COVID-19? What do? It's too late for them to institute lifestyle changes that are really long lasting. But what do they do? And I think there is a science behind some of the things that we can do. And, vitamin D, we talked about vitamin D in the past and now in the future. Vitamin D has been a long story. You've been talking about vitamin D longer than I have. And there are other things as well, things that are actually have some scientific plausibility, which I'd love to talk about. So again, like what we've been talking about, Rhonda, it's an all of the above type of thing. It's not just any one thing that's going to help. It's like, for instance, when you go to the operating room, right? We want to prevent infections. And so we don't think that just the doctor or the surgeon wearing the mask is going to solve everything. We also have a negative pressure or a positive pressure operating room, and we make sure that we use betadine or ChloraPrep on the incision. We're doing multiple things because nothing particularly by itself is going to be effective. And so some of the stuff we've been talking about today, like hydrotherapy, or we'll talk about vitamin D, none of those things by themselves is going to wipe out the pandemic. We have to do all of the other things that we know work, like wearing masks, over our nose and our face, and that's the other issue too. Is we're seeing a lot of this. People are in homes, and maybe it's their 8-year-old that's positive for COVID. What do? They can't just send their 8-year-old down the street and have them go to a motel. So what do you do in the home? And that just made me think of something else, because the CDC's just come out now with updated information about what to do in terms of ventilation. So the key in preventing yourself from getting COVID-19 is to make sure that you're not getting it from somebody directly from like large sputum or droplets. So you want to make sure that you're wearing a mask, that they're wearing a mask, that you're distanced. But also realize that if you're in a room that's stagnant, wearing a mask is not going to be 100% effective, because it's kind of like smoking, right? Somebody's smoking on the other side of the room, you may not smell it, but if you're in there for long enough, that smoke is going to fill up the room. And so what's really important is ventilation. Now, that may be hard to do that may be difficult to do in the wintertime when it's cold outside, but as much as possible, even just cracking the window a few inches, if you can do it, and maybe dressing more warmly, having ventilation in closed spaces can really do a lot. So it's all of the above. It's the mask wearing, it's the distancing, it's to make sure that you're not in an enclosed space for a long period of time with other people. Interestingly, you might wonder why people don't get the virus when they're on a plane. Well, that's a closed space and people are wearing masks. Well, you may not know this, but they do air changes like tenfold every hour. And all of that air is going through HEPA filters. And so the virus gets trapped. And that's why it works. As people are on planes for 5-6 hours, going across the continent, they're wearing masks, but they're not getting COVID-19. I mean, you might find a few examples where people might get it, but generally speaking, it's very successful. And why is that? It's because of ventilation. And so all of these things put together is really what the answer is. So following the recommendations, following what the CDC says. But here are some other things that we've talked about today that may also be beneficial. So I just want to make sure that everyone's clear on that.
Absolutely. I think it's super important to keep that in mind, that wearing a mask and social distancing and washing your hands, of course, as well, and ventilation are really important. And definitely, there's been so many studies now with mask wearing too, right? I mean, where even just, it doesn't have to be an N95 mask. I mean, even, someone wearing a cloth mask, it can both protect you from infecting others and also can actually filter out to some degree some particles that are, you won't be exposed to as many viral particles as if there were no mask, even if it's not a super high quality N95 mask, filtering out particles. So I found some of those studies to be reassuring, at least where it's like, okay, well, even, people wearing any kind of masks,
right,
helps. So yeah, thank you for bringing that up again, Dr. Seheult. Let's dive into vitamin D. As it's definitely a passion of mine. I'm a bit of an enthusiast, but I've published a couple of peer-reviewed studies back in 2014 and 15, and so I've been very familiar with the vitamin D literature for many years, and so when this pandemic first started, I was already familiar with the role of vitamin D in the immune system and also in preventing respiratory diseases, randomized controlled trials showing that. But maybe you can you've done a fantastic job covering the role of vitamin D in COVID-19, and early on as well. You were out there championing, that the vitamin D may play an important role, and you looked at, maybe we can talk about some of the observational studies and what the limitations are of those, and also some of the very, very preliminary, pilot randomized controlled trials that have been done. But maybe just start with some of the basics. Not everyone realizes that vitamin D can be a little, the name can be a little deceiving.
You're absolutely right. And this is one of the first things, and I know I'm preaching to the choir here. Those that have watched you know that vitamin D is so much more than just a vitamin. But I would encourage anybody who is interested in this is just Google vitamin D structure and look at the actual chemical structure of vitamin D. I got my bachelor's in chemistry, so that's the first thing that I naturally do is you can tell a lot. Yeah, good. So yeah, exactly. So that that if you look at the structure of vitamin D, it is very similar to the structure of cortisol, of the structure of testosterone, of estrogen, of progesterone. And what do we know about all of these other steroid hormones? They go directly into the nucleus of the cell where they affect transcription of protein factors. And depending on the cell type, it's going to have a different effect. So already right off the bat, you can see that vitamin D is doing something very different than what we would think of as just a vitamin where you need a cofactor to have an enzyme do A to B. It's much more nuanced than that. And very early on, the studies on vitamin D were involving calcium, bone metabolism. And so they came up with all of these things because they didn't know what else vitamin D did, really. I mean, they had some idea, but they came up with these standards. Oh, you need so much vitamin D for your bones to do whatever it needs to do in the calcium. And so it's the analogy I like to use is like, you're baking something, right? And you put so much flour into the recipe. It's as if to say that's the only thing that flour is good for is this one recipe, and that if you use flour for anything else, that's exactly the amount of flour that you have to use for any other recipe. Well, that's nonsense, of course. I mean, we know that we need a certain amount of vitamin D for proper bone metabolism, but why does that carry that that's the amount of vitamin D we need for a proper immune function? I mean, none of those things are there, and we have all of these standards about how much we need. We'll talk a little bit about the observational studies, but vitamin D is not just a vitamin. It literally falls more into hormonal. I mean, think about Addison's disease. Addison's disease is where you have antibodies that attack the adrenal gland. It's this tiny little gland that sits on top of your kidneys. The purpose of that adrenal gland is to make cortisol, aldosterone, androgens. These things are essential. In fact, if people lose their adrenal glands, they'll die. Because they don't have enough cortisol. Cortisol is essential for just the regular running of the body. And here we have this thing called vitamin D. The problem is we don't have a gland that makes vitamin D. We have the skin, right? So the skin through the sun and ultraviolet B radiation, which barely penetrates through the epidermis, it gets down to the dermis where the actual starting product is. And so if you don't get enough of this, you are going to be lacking in a whole host of things. So let's talk a little bit about what we found. And prior to COVID-19, we had some very good data on vitamin D. There was a wonderful meta-analysis. What's in a meta-analysis? Where they take a bunch of studies, they sort of chop them up, put it through a grinder, and they look and see what the overall is, so they can get a much bigger subject number. And Martineau, who is the lead author on that British Medical Journal meta-analysis that was done a number of years ago now, showed that supplementation with vitamin D decreased acute chest infections by 50%, significantly in that study. Also in the long aging health study called TILDA, in Ireland showed that vitamin D supplementation was beneficial. So we knew that there was immune properties. They found vitamin D receptors in the immune cells. And so all of this stuff is emerging. And then we get to COVID, and we start to see some really interesting studies coming out showing an association. Now that's an association, not necessarily causation, between a lot of the same things that we see in COVID, we see in vitamin D deficiency. So what do we see? The older you are, the more apt you are to get vitamin D deficiencies because your skin is not as effective at making vitamin D. And we saw there was an age predilection in COVID-19. What about race? We saw that race, particularly darker skinned people, were affected more in COVID-19. And that's not just, you could say, well, there's some confounders there, right? Because people who are ethnically darker may not have access to healthcare. Well, this carried even in those countries where there was socialized medicine, where everybody had access to healthcare, which doesn't erase that completely, but it was still a very strong association. We also saw it in not only in gender, but also big time in BMI. So the more obese you were, the less the vitamin D also. There was less in terms, or more morbidity in terms of COVID-19. But all of that got fleshed out in, I think, a beautiful study that was done here in the United States that looked at 191,000 people. And this was published by, it was published in PLOS ONE, the journal, an article titled SARS-CoV-2 Positivity Rates Associated with Circulating 25-Hydroxy Vitamin D Levels. So let's back up right there and talk a little bit about metabolism. You've got these cholesterol derivatives that get converted into vitamin D in the skin. Well, then that has to go to the liver for a 25 hydroxyl group to be put on one of the carbons. Now you've got 25 hydroxy vitamin D. This is what we measure in your blood. And then it gets converted into 125 dihydroxy vitamin D in the kidneys for metabolism, or in the white blood cells where they need it there. So we're looking at 25 hydroxy vitamin D. That's the storage form of vitamin D. And what they found was that as your levels started to drop below 50 nanograms per milliliter, we started to see an increase in SARS-CoV-2 positivity rate. And it didn't matter based on race, gender, geography, or age. All groups saw an increase in SARS-CoV-2 infections associated with a lower level of 25 hydroxy vitamin D. The lower these levels went, the higher the positivity rate. And that was just the beginning. I mean, this went on and on and on. No matter how you sliced it or diced it, there was this very strong association of vitamin D deficiency with higher rates of COVID, higher SARS-CoV-2 positivity rates, and higher admissions. We see people being admitted to the hospital had lower rates than those that had similar symptoms but were not SARS-CoV-2 positive. And, as you know, just because you have an association doesn't tell you that you have causation. The only way you could really find that out is by doing randomized controlled trials like we've talked about.
And so you mentioned admissions, but also mortality. Weren't there some studies also showing that patients that were more vitamin D deficient were more likely to have a severe case and even die versus ones that had higher vitamin D levels?
Absolutely, yeah. So that they showed that there was a difference in mortality, that there was a difference in which ones went on to need ventilators, and so all of this. So the question wasn't, was vitamin D involved in this somehow? The question was vitamin D the causative role, or vitamin D deficiency the causative role?
Right, and as you mentioned, because these are observational studies, one could argue, well, maybe low vitamin D is just biomarking unhealthy in general, right? I mean, and this is where, as you mentioned, randomized controlled trials are really key. But there's another type of study that I love to cite and talk about because it's a way, as you had mentioned previously, randomized controlled trials are very, very expensive to do. They're very difficult. They take a long time. It's a challenge. So another way of measuring more of a causative role of maybe of certain factors, and particularly in this case lifestyle factors, or something that I call vitamin D a lifestyle because you're making it from the sun. They're called Mendelian randomization studies, and essentially what they do is they measure. So everyone has, different variations in their sequence of DNA in their genes. And these variations often are just a change in one DNA nucleotide, which is called a single nucleotide polymorphism, or a SNP for short, as you know. But for people listening and watching, there are many different variations in genes that convert, for example, 25 hydroxy vitamin D, the major circulating metabolite of vitamin D, into 125 hydroxy vitamin D, which is the active steroid hormone. And these changes in just one nucleotide of DNA in these genes are associated with lower circulating levels of 25 hydroxy vitamin D because it's just that, different genes are doing different things, and sometimes genes get less active and sometimes they're more active based on this sequence change. So it's well known that these certain SNPs are associated with lower circulating 25 hydroxy vitamin D levels. And so there have been meta-analyses looking at people that have the SNP, didn't measure vitamin D levels at all. It's already known they have lower circulating levels. So you can't say, you're just measuring their low vitamin D, that's biomarking another health status. This is just genetics. We're just looking at a gene that's known to cause that. And these people have a much higher mortality from respiratory tract infections. They have a higher all-cause mortality. They have a higher cancer mortality. Cardiovascular-related mortality is unchanged. But respiratory tract infections are much higher. And so that Mendelian randomization study, I love to cite that because it really is establishing causation, because it's not, you're not just measuring vitamin D levels and then saying, well, maybe they're low in vitamin D because they don't go out and exercise, or maybe they're low in vitamin D because they're, obese and the, vitamin D is less bioavailable, which it is in obese individuals, as you mentioned. So the Mendelian randomization studies are another sort of, in addition to the randomized controlled trials, I think another piece of evidence that hints towards possible causation of vitamin D being important for preventing respiratory tract mortality as well.
Oh, that's amazing. I wasn't even aware of that. That's a great way of showing causation. And of course, they are working on some pilot studies that are trying to show randomization. But how big of a study was that?
It was quite large. I don't recall off the top of my head. I do have it linked in my notes. I can pull it up and send you. But there's been other SNPs in like the vitamin D receptor, for example. So children that have a single nucleotide polymorphism in the vitamin D receptor, they also have a higher mortality from respiratory tract infections as well. So vitamin D, as you mentioned, it's a steroid hormone. It's going into the nucleus. It is, it binds to the vitamin D receptor, which then heterodimerizes with another receptor called the retinoid receptor. And that complex, goes in and into the nucleus where your DNA is, and it recognizes a very specific sequence of DNA called a vitamin D response element. And these are in more than 5% of the protein encoding human genome. I mean, that's a lot of genes vitamin D is regulating in all sorts of tissues, brain, in the immune cells, and other organs as well. So I do think, thinking about mechanism, and I know you've talked about, the role looking, at underlying mechanisms. How does vitamin D regulate the immune system? I mean, there's a variety of ways. And specifically, it's really interesting. And I'm getting off topic here. I want to get to the pilot randomized controlled trials, but are you aware of the role vitamin D plays in the ACE2 and renin-angiotensin system?
I know there is a connection. I was actually reading that just briefly. I think you're the one that sent me the article, but I need to remind myself.
We covered it back in March or April. I think I did a short little Q&A podcast on it. And it's really interesting. You know much more about the renin-angiotensin system than I do as a medical practitioner, which, it obviously plays an important role in regulating blood pressure and fluid homeostasis, and, I think even in the lungs too. But what's interesting about the vitamin D renin-angiotensin system, it converges on the ACE2 receptor, which, as you know, and probably most of the world has heard by now, is how the SARS-CoV-2 virus enters into our cells. It binds that receptor. Well, what's been shown with SARS-CoV-1 is when the virus, which also binds to the same receptor to get inside of the cell, it binds to the receptor and it internalizes the receptor and downregulates ACE2, which is not good because that is really important for this renin-angiotensin regulation, as you know, Dr. Seheult. So that's been shown with SARS-CoV-1. And what happens when the ACE2 gets downregulated, lung injury, acute lung injury, gets really bad. And so there's been some animal studies that have found, for example, if you high dose with the active form of vitamin D, the animals, and then you cause acute lung injury, ACE2 goes down, acute lung injury goes up in the placebo group, but the vitamin D group, it normalizes the ACE2 levels. So if you think about it, another potential, this is a hypothesis, of course, another potential way vitamin D could be playing an important role in this specific virus is through regulating ACE2 levels. And what's interesting is that there was just a very recent study that came out. ACE2, the gene, it's located on the X chromosome, and women have two X chromosomes most of the time. One of those X chromosomes, the gene's inactivated, but there are genes that escape that, and ACE2 is one of those. And so women have much higher levels of ACE2, and so researchers are thinking this is protecting them from a more severe COVID-19 outcome because they're getting that ACE2 levels higher in terms of, you'd think, oh, well, more ACE2, that means the virus is getting in. But actually, biology always tricks you. It always, you always think one thing, and then it's like this beautiful, sort of complex scenario. But I'm digressing, and I just kind of wanted to bounce that off you because you're such a scholar, and I thought you probably would find that interesting. And I certainly hope scientists are testing that hypothesis because it seems very relevant.
Yeah, it does. Not only that, the human body is so complex, as you say, that there's so many connections. The other aspect of angiotensin, or ACE2, I should say, is that it gets rid of pro-oxidative products, and it increases antioxidant products. So, for instance, angiotensin 2 and angiotensin 1,7, those are in balance, and ACE2 tries to keep those in balance. But when ACE2 is knocked out by either SARS-CoV-2 or SARS-1, the amount of oxidative stress goes up dramatically. And what we see that may play a role in terms of thrombosis. So you have oxidative stress in the ACE2 receptors in the endothelium of the vasculature. That causes inflammatory stress, oxidative stress, that causes thrombosis, and that's where that happens as well. So all of these things, it seems as though we've got the dots. Connecting them requires very good randomized controlled trials. But again, like you said, hypothesis-driving type of studies that may answer that question.
That was very enlightening. I do remember reading about that, and wow, I didn't realize it played the role in the thrombosis as well. So that's super interesting. But as you mentioned, yes, randomized controlled trials are key, and there have been. I've seen, one stronger but small trial that was published. Was it back in September? That found this was I think it was it Spain, perhaps?
Yes. Yep. It was October. I've got it pulled up here. October of 2020, and it was a Spanish. It was Marta Castillo who published. She was the lead author on this one out of Spain. There was a little issues with the randomization, so probably the effect was overemphasized. But if you look at the effects, they were quite dramatic. There, in the calcifediol group. Let's just back up a little bit. What's calcifediol? That's the name that we give to 25-hydroxy vitamin D. So in this study, they didn't give just vitamin D. They gave the product of the metabolism in the liver of vitamin D.
Now, do you think that's important for someone that is undergoing, let's say, if you're so sick and maybe your liver's not working properly, your kidneys aren't working, how are you going to convert these vitamin D metabolites into this steroid hormone, right? So, do you think it's important to give someone that more downstream, like an active form versus vitamin D3, for example?
Exactly. And so that's the question, is whether, because it takes some time for the vitamin D to be metabolized in the liver. I've seen some people say up to 7 days. It probably is a little bit less than that. But when you have when you're giving vitamin D in the acute situation, it doesn't really matter if you're just supplementing over a long period of time and you're hoping to prevent yourself from having a bad outcome with COVID-19. But if you've already got COVID-19, what they may be saying here is that supplementing not with vitamin D, the product prior to liver metabolism, but in fact calcifediol, 25-hydroxy vitamin D, might be a more efficacious intervention. And that's what they did in this study.
And another thing this sort of brings to my mind, you'd mentioned the pre-pandemic studies looking at randomized controlled trials looking at the role of vitamin D supplementation in preventing respiratory tract infections. I believe it was Martineau.
Yes.
That was the senior author on that.
Yes.
And what was so interesting about those meta-analyses was that they found weekly doses, daily doses worked, but monthly doses did not in terms of protecting against acute respiratory tract infections.
And
to me, it's like we can't learn from past. Like there's something wrong. We need, so when you're designing a clinical trial, you need to be familiar with the literature and see, there's these meta-analysis showing that monthly doses don't work. maybe we shouldn't design the trial that way. Maybe we shouldn't just do one large dose, which I think I've seen a preprint floating around for COVID-19 where there was one large dose and there was no effect.
Yes. You're referring to the Brazilian study where they gave 200,000 international units at the very beginning.
Yes, I don't believe it's peer reviewed yet. Am I correct?
At least
on
I haven't
saying
seen
that?
it yet.
Okay.
This study, though, this Spanish study, where they gave something called calcifediol, which is, again, is 25-hydroxy, and this is not an over-the-counter medication. This is a prescription only. It's usually prescribed by nephrologists in patients with renal disease that have very high parathyroid hormone levels. And they gave it on day 1, they gave it on day, I believe, 3, and then again at day 7. And what they found was in the calcifediol group, there was only 2% that went to the intensive care unit, whereas in the placebo group, 50% of those went to the intensive care unit. So that's a very, very marked number. Again, there was, I think the British recently got together and looked at all of the data, and you may have known they made a recommendation that there still was not enough evidence to cause supplementation to prevent COVID-19. Interestingly, they discounted this Spanish study because they felt that the randomization was not good enough. But there's been some mathematicians that have looked at this study and said that it would be impossible for that randomization to fully describe what happened in this study. In other words, they believe that there was an effect of calcifediol in this study.
And it seems very likely if we have, as you mentioned, meta-analyses of many, over 25 different randomized controlled trials showing vitamin D supplementation improves, prevents respiratory tract infections, in people that are vitamin D deficient between 50 to 70%, and it even still had an effect in people that had normal sufficient levels of vitamin D. Maybe we can talk about what those are. But what would make, of course, viruses are different, but a respiratory tract infection, to some degree, there's got to be some common denominators, right? So it would seem, to me, logical that something like vitamin D, where in the United States, 70% of the U.S. population is categorized as vitamin D insufficient, which defined as by the Endocrine Society is less than 30 nanograms per milliliter. And 30% of the U.S. population is what is called vitamin D deficient. So they have less than 20 nanograms per milliliter blood levels of 25-hydroxy vitamin D, which is the major, circulating metabolite of vitamin D. So, it's the question becomes, and maybe we can talk a little bit about vitamin D supplementation and safety, but is it really, you don't have to make a bold statement that it's going to prevent COVID-19. Absolutely, we should be following the CDC guidelines on social distancing, on wearing masks, on washing our hands, and also, as soon as they become available, vaccinations. But in addition to following the CDC guidelines, it might be prudent to say it's probably important to become vitamin D sufficient. In other words, if we already have data that 70% of the U.S. population, has insufficient levels of vitamin D, then clearly people need to take a vitamin D supplement. And, I think, or maybe need to get their levels measured. The best way is to go to a doctor, get your vitamin D levels measured, and then see what those are, and then take a supplement to bring them up. And the reason I say that is because, as you mentioned, we make vitamin D in our skin. But depending on where you live, you said UVB radiation is how we make it in the skin. Depending on where you live, many parts of the year, UVB radiation is not even hitting the atmosphere, right?
Exactly. And so if you live above the 35th parallel, which if you're in the United States, that would be the southern border of Tennessee, or just a few miles north of us here in Southern California, most of the country lives above the 35th parallel, which means that you're not going to get enough UVB radiation in the winter months to supplement or to keep elevated your vitamin D levels sufficiently. And so you've got to take supplementation.
And sunscreen blocks UVB radiation, and most people are wearing sunscreen. Most people are indoors now. Work is, we're on our computers. We're not out. We're not an agrarian society like we used to be. People aren't out in the sun all the time. People are inside. I mean, if you look at NHANES data over the past couple of decades, you see vitamin D levels are steadily just going down, 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 down. And I think that's because most people are now spending more time indoors. Also, as you mentioned, people like African Americans, people with darker skin have much lower levels of vitamin D. In fact, African Americans, this was NHANES data, the most recent NHANES data that was published, they're 30 times more likely to be vitamin D deficient than Caucasians. And the reason for that is because melanin is a natural sunscreen. I mean, it protects you from the burning rays of the sun. So if you live in Australia or closer to the equator, Somalia, for example, that's great because you're getting a lot of UVB exposure year round. But when you take a person and they migrate, say they move from Africa to New York City, to Chicago, well, it becomes a problem because you're much further from the equator. And now you've got this natural sunscreen that helps you, protect you from the burning rays of the sun. And now you're living in a place where you're not getting as much sun. And so there was a study that came out of the University of Chicago a few years ago that found African Americans in Chicago have to stay in the sun 6 times as long as a Caucasian to make the same amount of vitamin D in the skin.
Yeah, I believe it. And the other thing, people say, well, if that's the case, then how come people are getting COVID-19 in sunny places and hot places? For instance, if you remember back in the early part of summer, there was a huge epidemic in Arizona and also in Florida and Texas. Well, I mean, if you think about it, yeah, there's a lot of sun, but if you're inside, you're not going to get exposed to the sun.
Right. You think people in Arizona are going out in the sun in the summer? Dude, it's like living in the winter when it's summer. I lived in Tennessee for 6 years, and I'm from Southern California, so summers I was used to spending on the beach. When I went to graduate school, summers became like winter because I did not want to be outside. It was like 95 degrees, humidity, hot. I mean, so I spent way more time inside in the summer in Tennessee than I did in the winter in Southern California.
And here's the other thing, too, is that UVB barely gets through the atmosphere down to us, and it does hit us when we're outside, and the sun's got to be pretty high up in the sky. You go behind a piece of glass, there's almost no UVB at all. The only thing that's coming through is UVA, which is nasty ultraviolet radiation. It makes your furniture fade, your carpet fade, and it gives you aging wrinkles on your skin. So if you think that you're sitting by the window is going to give you some nice vitamin D, think again.
And clothing, right? Clothing
exactly
also blocks it. So the question becomes, why is the vitamin D insufficiency and deficiency is so prevalent in our country, and also in places like the UK, where you said they're not finding enough evidence to recommend vitamin D to prevent COVID. Well, maybe that's a strong statement, and you need more randomized controlled trials to make a extraordinary claim like that. But you can still make a claim that it's probably in your best health interest to maintain good levels of vitamin D, and that because we know vitamin D deficiency is so prevalent, that it's probably best to get a vitamin D test and measure your levels and take a vitamin D supplement.
Exactly. And the thing that's a little confusing too is that a lot of these levels that we've come up with are based on the endocrinological function of vitamin D with bone metabolism. We don't know if that's the value that we need for immunological functioning or COVID. What we do are some associative studies that seem to show, at least in those studies that we talked about earlier, where they looked at 191,000 people, that SARS-CoV-2 rates started to go up once levels drop below 50. So that's an interesting number.
That's interesting. There was a few back in 2013. There was a meta-analysis published. I don't know the author's name, but the studies dated back from the 1960s to the 2013, and it was looking at all-cause mortality in association with vitamin D blood levels. And it was found that levels somewhere between 40 to 60 or 70, like it was the lowest all-cause mortality. So like there was this sweet spot, and of course it's one of those things where, associative studies there's always the problems that people try to, correct for confounding factors. And, but the idea is to look, and this is what you've done such a fantastic job, with your scholarly work at MedCram Videos, is looking at the whole body of evidence, the observational data, the mechanistic data, the case studies, and if there are randomized controlled trials, the animal studies as well, because that helps give us some insight on mechanism. And of course, you can't translate an animal study to humans, but if you take the whole body of data, right, everything together, then you can begin to tell a story as well. So in terms of supplementation, though, it's the upper tolerable intake that's been set by the Institute of Medicine has been 4,000 IUs a day. And what about, vitamin D is a fat-soluble vitamin. What about toxicity?
Toxicity, there was a statement that I read that said that vitamin D is probably the least toxic fat-soluble vitamin. So there was a study where this Polish guy looked at Polish scientists looked at the Mayo Clinic's database, and they looked at 20,000 people. And we've talked about this in their video that we recently published. One person had hypercalcemia out of those 20,000, and they had ranges, people supplementing anywhere from 0 to 55,000 units a day. And really just one person. And that person's vitamin D level, if I recall correctly, was up in the 200, 300 range. That's nanograms per milliliter. And that's not
hard to do.
Yeah, it's massive.
Yeah, I remember reading a study, and I'm sure you've seen this one, where there was the long-term supplementation with 10,000 IUs a day, and it was really no toxic effect. And that was I forgot how long-term it was, but
yeah. The other thing that I've seen is that it's not a linear response curve. So as you go up in supplementation, it's not like your nanograms per milliliter are going to go up linearly. What we notice actually is that the first 1,000 units that you supplement causes an increase of about 4.8 to 5 nanograms per milliliter, whereas when you get up to about 15, 20, 30,000, that each additional 1,000 goes up by about a tenth of that. So it's a non-linear relationship. It's exponential, but the reverse of exponential. As you go up higher and higher, the increment becomes less and less. It's almost like you're saturating receptors, if you will. It's probably not the case, but that's what it seems to be like.
Do you measure vitamin D levels in your patients, or is that something that's common in the hospitals you work in? Yes, so we have been doing it. It's problematic if you don't have a lab that does it quickly, so you get the result back in 2 to 3 days, which you kind of want to know that up front. So we will supplement and then wait for those levels to come back. But most of them are low, and there's been studies on this too that have shown that most of these patients, specifically with COVID, are coming back positive. They're coming back with low vitamin D levels. What they did in one study, they wanted to see whether or not it was the symptoms that were causing the low vitamin D. So they took these patients and they said, okay, anybody that has X, Y, and Z symptoms we're going to look at. And then they figured out which ones were COVID and which ones were COVID negative. Well, the ones that were positive for COVID and had the same symptoms had lower vitamin D levels than those people that had similar symptoms but were negative for COVID. So it's not just the symptoms of COVID that's causing the low vitamin D levels. It's something about COVID itself that seems to be doing it. Wow. So you guys are in your in the ICU where you're treating patients, you guys are giving patients vitamin D. Oh yeah. That's great. Is that something that's being spread amongst hospitals? Do you know? I hope so. I'll tell you what we're doing based on the SHADE study. This is another randomized controlled trial that came out of India. And it showed basically when they supplemented patients in the hospital with 60,000 units a day for 7 days, that there was an improvement by day 21 in the number of COVID negative patients on testing. Now, that's probably not the best surrogate because, PCR picks up any little detectable fragment of RNA and
gives you a positivity. It's a surrogate, but it was like 60 versus 20% at week 3 were negative by just supplementing with vitamin D. The other thing that they looked at was fibrinogen, which was a marker of inflammation. That was significantly lower as well. So based on that study, we don't have 60,000 units typically here in the hospital. We have 50,000. So I figured the 50 versus 60 is going to be a very small difference. And so that's currently what I'm doing in my patients, and I'm recommending to my colleagues to do the same. We haven't seen any toxicity. There was no toxicity in that randomized controlled trial either.
So you're kind of just assuming from right out the bat that most likely patients are low in vitamin D, I mean, which I think is a reasonable assumption considering NHANES data showing that 70% of the U.S. population is insufficient.
Correct. And if they're not, it's probably not going to hurt them if we do it for just 7 days.
Right. Well, I'm looking forward to more, data on vitamin D in terms of randomized controlled trials. I only hope these randomized controlled trials are designed properly. And, there's so many factors when it comes to something that's nutrition related or something that, you can make from the sun. It's always important, it's not like a drug. When you do a randomized controlled trial with a drug, a pharmaceutical, drug, people have 0 levels of that in their body to start with. You give them that drug or the placebo, and it's obviously, they're going from 0 to something. Whereas with something like vitamin D and also with in nutrition in general, you have to measure things at baseline. You have to quantify.
Right.
You have to have something quantifiable. And I've seen randomized controlled trials, believe it or not, with vitamin D where they don't measure vitamin D levels. They just give them the supplement, and it blows my mind. That can even get past peer review, or how do you design a trial that way? I mean, it's adding to the confusion, in my opinion. So I'm hoping that because of the seriousness of this pandemic, that people designing these trials are doing so carefully. Like the fact that we know from previous data that one high monthly dose of vitamin D may not be enough. It may not do the job, right? And as you mentioned, maybe that's because it doesn't bring their levels up because it's not happening in a linear way, right?
So there was a great study that looked at that in France. Apparently the practice was that every nursing home patient would get 80,000 international units of vitamin D every 3 months. And when COVID hit, these patients were being admitted to the hospital, they asked a very interesting question. What they did was it was kind of a quasi-randomized study. As they were being admitted, they would ask the question, so how long has it been since you got your 80,000 international units of vitamin D? And when they not randomized, what they sorted them to those that had gotten it within the last 30 days to those that had gotten it past 30 days, there was a statistically significant, clinically significant difference between those that had gotten it recently and those that have gotten it more than a month out. Wow.
And do you ever have people just tell you, well, just go out in the sun more, or, eat some food that's high in vitamin D? I mean, what do you say to people that might say such a thing?
Well, you don't know if it's working. So I was taking 2, and I'm not living at the North Pole here. I'm in Southern California, like you, and I was taking 2,000 units a day, and I wanted to get up above 50 because of some of that data that I showed. So when my levels were tested, I work outside. I don't like working inside a lot, so I go outside too. I do gardening. I like working around the garden and stuff. That plus 2,000 units in the middle of summer, and I was at 48.
Wow.
So that tells you that
right.
That you may have to work a little bit harder than you think at getting your vitamin D levels up.
Yeah, and I think again, depending on how much melanin you have in your skin, depending on your age, you're anywhere between 2 or 4 times less likely to make as much as you were when you were younger. Depending on all that stuff, are you wearing sunscreen, where you live, what time of year it is, all those factors. I mean, so just to say, go out in the sun more. What if you're an African American living in Chicago and it's November? What are you going to do?
Right. And in the middle of winter, the sun's pretty low. So it's probably, there's not a lot of UVB probably that's coming through, ultraviolet B radiation. It's got to go through a lot more atmosphere to hit you when the sun is that low in the sky.
Right, exactly. And the other thing is people think you can just get it from your diet. And this is another sort of factor that I really would like to address, because, the reality is, the foods that have been, first of all, the food that's been fortified with vitamin D the most is milk. And unfortunately, there's a lot of people that are lactose intolerant. Mm-hmm. And 75% of African Americans are lactose intolerant. And there have been studies that have shown that, for example, African American women that have a single nucleotide polymorphism in the lactase gene that allows them to, tolerate lactose, they have much higher levels of vitamin D because they're drinking milk.
Yeah.
So fatty fish, salmon, like 4 ounces have close to 400 IUs maybe. But, people aren't eating fish. So in the United States, they're not. I mean, maybe in Norway or Japan, and of course, omega-3, is also very important. And I also think it's very important to get enough omega-3, particularly now because of the role of omega-3 in inflammation. And, there have been some interesting studies showing that omega-3 supplementation, there's been a meta-analysis showing that supplementation in hospitals prevents ICU stay or lowers ICU stay, prevents mortality and by up to 60%. I think this was parenteral. When they're giving it?
Yeah, the IV.
Yeah, they're giving it through the IV, as well as there's been other studies showing it helps prevent, as I mentioned to you, it was a venous thrombosis.
Yeah.
But my point is, vitamin D is in the fish. Most people aren't eating fish. So a supplement it's really the easiest low-hanging fruit. As you mentioned, it's really hard to get people to change their lifestyle. We know, for example, that people with metabolic syndrome, with type 2 diabetes, that are obese, high blood pressure, have much, higher risk of a severe COVID-19 outcome, right? But to get someone to completely reverse their type 2 diabetes is a lot of work. We know things that can do it in diet, cut out the refined sugars and exercise. And there are things that can reverse type 2 diabetes. But that takes, motivation. You have to want to do that. It takes a lot of effort and it takes some time.
Yeah.
Whereas, I think most people can take a vitamin D supplement. It's one of the cheapest. It's literally like a penny a pill. It's one of the most affordable supplements ever. And in my opinion, one of the most important, because of the widespread deficiency, because of the way our society is now, where we have migrated to other places, we're indoors much of the time. And it's just a very different world that we live in, compared to, 1,000 years ago. Or maybe that's too far back, but you get my point.
Yeah, there's so many things that are involved with it. And I'm of the opinion too, just because of some of my sleep background as well, that I do believe that there is a benefit from actually getting out into the sun. So I don't say that going out into the sun is the only way you can do it or should be the only way. I believe in supplementation. I supplement as well. But there is something to be said for getting outside into the fresh air and sunlight and allowing that light to hit the back of your retina. It has wonderful effects in terms of getting your circadian rhythm on sync. So, yeah, I think one of the things that we need to learn about is it's not an or, it's an and. It's an all of the above type of thing. And just because you supplement doesn't mean you should go in the sun. Just because you go in the sun doesn't mean you shouldn't supplement.
Oh, I 100% agree. Thank you for bringing the circadian rhythm up. That it's one of the things that I've noticed, having early bright light exposure and setting my circadian clock is one of the most important things that has helped me sleep better at night, because my clock is set early.
Yeah. And,
my body starts to produce melatonin at a reasonable time, as long as I don't have bright lights, blue light on in my house all night. But you also are in the sleep medicine, and you run you have do you run a sleep clinic, or you're involved in this sleep clinic?
I have a sleep clinic, and I also am the medical director of a sleep lab as well.
So what are some of the things? Sleep is also very important for immune function, and what are some of the things that you're helping your patients do in terms of sleeping better and helping? So
sleep is a very complicated topic, because everybody may have problems sleeping, but it's for a myriad of different reasons. It could be medical reasons, could be just, maladaptive behaviors. But what the point I want to make is that sleep and the immune system are intimately connected. We know for a fact that people who get more sleep before they get an immunization have a better immune response with higher antibody titers to, for instance, the flu vaccine. We know that when people are challenged with a virus, they actually did this study where they put rhinovirus into subjects' noses on purpose. Living on a college campus, people will do any study for for very little money, so it's easy to get those kind of students. But this is what they did. They subjected them to rhinovirus, and they put it into their nose, and they waited to see how many people came down with the common cold. And when they looked back and saw what their sleep habits were, it was a 5 to 7-fold difference if you looked at those people that got 7 or more hours of sleep per night versus those that got less, and whether or not they had a good sleep efficiency. So sleep efficiency is how many hours you're actually sleeping divided by the number of hours that you're in bed. And so you have good sleep efficiency, you've got good hours of sleep, so good quality, good quantity. Your risk of getting any kind of virus, like rhinovirus, adenovirus, those sorts of things, is cut by 5 to 7-fold. That's a massive number when you consider what we're trying to do to reduce the incidence of COVID-19 right now with vaccinations and things of that nature. That just a good night's sleep can have that much of an impact. It's not a cure, but it certainly is somewhere to start.
That's a very robust difference. I mean, I know I probably speak for many other people. I know from personal experience, absolutely 100%, if I get a bad night's sleep and I've been exposed to a virus, it'll take me down. This seems very relevant right now with vaccinations that, sleep plays such an important role in the antibody titer and how many antibodies you're producing. But even in more general sense, I mean, the fact that sleep is so important for just immune function. So what do we know some of the mechanisms? I mean, I don't want to get too much.
One of the mechanisms that's involved has to do with the stickiness with how those immune cells stick to each other. And that's regulated. That's regulated by you would probably not be surprised, by G proteins and cyclic AMP and second messenger systems. And what we notice is that when you sleep more, your cortisol levels are lower. And cortisol, of course, is cortisol and epinephrine and all of these other beta-adrenergic systems affect the G protein, stimulate the G protein, causes increasing cyclic AMP in these immune cells, and they make those proteins, like the major histocompatibility complex 1 and 2, less sticky. And so it impairs your immune system when you have higher levels of cortisol, higher levels of stress.
Mm-hmm. And really interesting study, since you just mentioned the light exposure and helping with sleep. I saw there was one study where people were exposed to 10,000 lux of light, and I believe it was for like a significant period, like 6 hours. Like where you're like literally like it's a weekend, you're outside at the beach or something, you're outdoors, and it lowered their cortisol levels by 25%, I think, during the phase where it's not supposed to be high or something. Because cortisol obviously wakes you up. I mean, your cortisol is regulated in a circadian manner, yep. And it it's important for waking you up. But the problem is that people are having higher cortisol from psychological stress. From what are some other things that raise people's cortisol?
Yeah. Oh, so other things like sleep apnea. That's a big one.
Sleep apnea.
Yeah, sleep apnea.
Basically, just the lack of sleep
tied to obesity.
What are some of the main practices that you tell your patients? Like, what have you found some of the most robust practices for improving sleep? Like,
okay. Yeah. So
maybe the lowest hanging fruit too. So like
question.
Things that are lowest hanging fruit and things that are more robust.
So the most important time of sleep is the sleep that you get at the beginning of the night. There's really two types of sleep that are the best at making you feel healthy, and they are slow wave sleep which is right at the beginning of the night. In fact, this is the type of sleep that is associated with growth hormone secretion, especially in children. This is if there was ever the fountain of youth, this would be it. Growth hormone makes you feel younger, makes you look younger. I mean, it's. In fact, we were giving growth hormone injections many years ago until we realized that it can cause problems because of where they were getting it from. But that's another story. But growth hormone and slow wave sleep at the beginning of the night is very, very important. Yeah, REM sleep is toward the end of the night. That's when you dream, and that's also a good part of sleep as well. But nothing beats slow wave sleep with these large delta waves. If you were to look at this on a polysomnography, so the most important time to sleep is really that time before midnight. And there's a lot of research in the last 4 or 5 years that has been going into this holy grail of slow wave sleep and what happens at the beginning of night. So with that being said, think about what's going on in the United States right now, okay? And over the last 50 years. We've essentially turned night into day, right? If you've ever seen those satellite pictures of what the United States looks like at night, it's lit up on both coasts. And if you look at our area here in Southern California, it's very bright. It's probably one of the brightest in the nation, probably only second to New York and the DC, New York, area. But here's what's happening. People are coming home later. They're, eating later, staying up later. They got a lot of work to do. And they're putting their faces in front of screens, which is emitting light. Now, what does that light do at that hour? What that light does at that hour in just about everybody is it shifts the circadian rhythm and delays it. So whereas you would feel sleepy normally at, let's say, 9 or 10 o'clock at night, you're now going to start to feel sleepy at 11 or 12 o'clock at night. And so you don't go to bed until later. So you would normally be waking up 7, 8, 9 hours later because that's how much sleep you're really supposed to get. But unfortunately, that goes into 8, 9 o'clock in the morning. And you're supposed to be already at work at your desk, or now with COVID, you're at home working somewhere. Or because of the fact that there's so much density, you've got to get up at 4 in the morning, 5 in the morning to get in your car to do your 2-hour commute to beat the traffic to get at your desk. And so what we've done essentially over the last 50 years is we have sandwiched the amount of available hours that we have for sleep. And what's been cut off is that first part of the night before 12 o'clock, where the best, most restful part of the night is going to happen. It's been said many times, and from people hundreds of years ago, I don't know how they knew this, but over 100 years ago, they said that 2 hours of sleep before midnight is worth more than 4 hours of sleep after midnight. And the science is actually showing that to be true. It's amazing.
So that the thing that I have found to be, the two things I have found to be most effective, or maybe three, in making sure that I am not a night owl. I mean, some people, there are genes that do control this, and there are some people that are genetically, they're night owls, and there are some genes that actually allow people to get less sleep, but those are sort of a lot more rare.
Right.
But what I have found for me is bright light exposure. So you wake up in the morning, and what do most people do? They want coffee because they're sleepy and they didn't get enough sleep, and so they're trying to counter that with some caffeine, right?
Right.
Maybe they should step outside. Step outside for 30 minutes. Maybe drink your coffee outside. Go for a walk. If it's cold out, drink your hot coffee and do some stretches or yoga or something. But go outside and set that clock so that your circadian rhythm sets earlier, so that you start making melatonin earlier.
That's
However,
exactly right.
In order to make melatonin earlier, I previously around our house we had these Philips Hue lights, which basically you can program them to turn red at a certain time. So red would be something that isn't as disruptive to melatonin production because, as you know, blue light is what disrupts it. And so you can program them to, let's say, come on at 5 p.m. And so now all the lights in your house are red rather than bright light. Now I have dimmers, and dimmers also really help because I just dim them so low that, at night it's like all the any light that's on in our house is very, very, very dim. And the other thing is that, well, now I try not to like work and get on my laptop and answer anything that gives me emotional stimulation.
Right.
If whether or not it's bad, or like, don't look at social media. Like, I don't want to see a bad comment, or like, anything like that, that'll get me upset. That'll completely throw off my sleep. But there are apps that you can put on your computers and phones that like block out some of the blue light, or you can wear the orange glasses. I personally find that even watching TV, that'll stimulate me. And so that, I actually prefer to just chill out, and maybe read a book, or you just kind of decompress. But like the avoiding blue light at night and getting the bright light exposure, I think those are the two really main things that have gotten to me. I go to bed, I'm like in bed and asleep by 9:30.
Yeah, so that is exactly, you asked me the question, what's the low-hanging fruit, and you just answered it. That's exactly what I would recommend, and that's what I do recommend. Now, from there, people have different problems. People have sleep fragmentation where they wake up a lot. Some people can't fall asleep. Some people can't stay asleep. We could come back and do another 2 hours on recommendations for each one of those things, and each one's an individual, so it's hard to say, but the kind of the sleep hygiene stuff that we've just talked about can go a long way in getting you started on finding your fitness, basically.
Yeah. Other things, exercise. Some people think the sauna, which sauna is something that you and I both, you've recently developed a passion for. Yeah. So you tell me, it's something I've been passionate about for many years, in public speaking about. You've dove into a little bit about the effects of heat stress in terms of sauna use on the immune system and lung function, respiratory tract infections, which is also very relevant now.
Yes, exactly. So vitamin D gets me excited. Talking about sleep gets me excited, but nothing gets me more excited than talking about this. This is really amazing stuff, because I have a feeling that it could be helpful in COVID-19. It makes plausible sense. Let me tell you the evidence for that, just sort of offhand. Okay. So I said at the beginning that you've got to look at COVID-19 as a timing issue. Early on in the disease, we've got good evidence now from immunologists that SARS-CoV-1, SARS-CoV-2, and MERS, all three of those, they kind of act the same way in that early on in the disease, they suppress the innate immune system. So there's two parts to your immune system. There's the innate immune system, that's sort of the garbage collector that goes around looking for stuff that shouldn't be there and eating it up. What are the tools of that innate immune system? Fever is a big tool of that innate immune system. Interferon, the substance called interferon. There's gamma interferon, beta interferon, alpha interferon. All of these things are the tools of that innate immune system. The other part of the immune system is the adaptive immune system. That's B cells, T cells. That's what we're using with the vaccination. What I'm talking about is the innate immune system. And early on, this virus suppresses the body's ability to mount that response. The thing about the innate immune system is it's very robust in children. But as you get older, its efficacy diminishes with time. So that's why we see fevers all the time in pediatric populations. They get a virus, they get a fever. But we're not seeing the fever so much in the adult population, and certainly not as much as we would expect to see in SARS-CoV-2. Now, that being said, as the virus, using various techniques, proteins, things that it does, as it suppresses that immune system, you get this low-level viral infection that goes on for days. And then finally, the adaptive immune system kicks in, and you get this cytokine explosion that ends people up in the hospital with pneumonia. So again, it's a timing issue. The question is, in COVID-19, do you want to suppress the immune system, or do you want to elevate the immune system? And the answer is yes, because you want to enhance the immune system at the beginning so that it gets rid of the virus. But notice that all the things that work late, like steroids, suppress the immune system. So you've got to be very careful about which phase you're looking at. Okay, so what they've done, there's a couple of papers that were published in Science about a month or two ago. They could explain 14% of all of the severe cases in their cohort based on two findings. One was a bunch of genetic mutations that basically left the subjects hamstrung in terms of secreting and producing interferon. So interferon production is a complicated system. There's many genes involved with it. And at many points along that pathway, there were mutations that basically caused the interferon secretion levels to be nil. All of those mutations were found only in the severe COVID-19 patients. Okay? Did not find any of these in the mild patients. So again, there is some causation there, like you were talking about before with the SNPs in vitamin D.
Yeah.
The other one that made up about 10% was older patients that had developed antibodies to interferon. So essentially, their interferon levels, even though they were being produced, they were being inactivated. All of these patients that had antibodies against SARS-CoV or against interferon were in the severe, none in the mild to moderate group. So what they determined was that, and other studies have borne this out, that in order to predict a mild to moderate course of the disease, you had to have an adequate interferon response early on in the course. And you wanted to have that to lead to a mild to moderate. If you did not have a good interferon response early on, that would lead to severe disease in almost all of those cases. With that in mind, what I started to do was look at a number of things. Number one, looking at heat. So there was a number of studies actually that have been produced. Some at the University of Toronto, some also in other centers as well, that showed that if you take human beings and heat them up in a hot water bath, 39 degrees centigrade, the purpose of this is not to kill the virus. The purpose of this is to enhance the immunity. And what they found was that they were able to, independently of these potential mutations, that fever or temperature itself was able to cause a secretion, an elevation in interferon, tumor necrosis factor, those sorts of things. There's one study that they did where they took subjects, put them in hot water baths at various degrees, so 38.5, 39, 39.5, etc. And when they took the monocytes out of their body and put them on the Petri dish and exposed it at various temperatures to LPS, which is lipopolysaccharide, which is a universal activator of the immune system, that interferon levels were 10 times higher once they got up to about 39 degrees centigrade or Celsius, which is around where you start to have a fever. So lots of plausibility there. Okay, so now what we did is I looked back in history, and I thought, well, maybe if we started to heat up their bodies, maybe there could be some immunity. Think again about the fact that 80% of all symptomatic COVID-19 patients, 80% never need to go to the hospital. Why? Because their innate immune system does the job. It takes care of the virus. 20% end up going to the hospital. If we could somehow increase that 80% to 85, 90%, that would have a huge impact on the number of people that are seeking medical attention right now in the hospitals. So I decided to look back. So there was the flu epidemic of 1918 and 1919, and it got to the point in the United States. Now remember, this is before oxygen. This is before randomized placebo-controlled trials. This is before the discovery of penicillin even. There was two thoughts about how to treat this pandemic or this epidemic of the flu. And as these soldiers were coming back from World War I and bringing the flu with them, there was a lot of army hospitals that were treating these patients. And the thought was that it was the symptoms of the flu that was killing these patients. Well, we knew how to treat fever by giving aspirin. Aspirin had just been discovered in 1899 by the German company Bayer. And so a lot of Bayer aspirin was being used to get rid of fever, to get rid of symptoms, and we knew exactly how that went in the army camps. That was the one way of treating it. The other way of treating it was by doing what we've just been talking about, which was rest, exercise, or not exercise, but rest, sunlight, fresh air, and hydrotherapy. And this was the type of pattern that was being used in a number of sanitariums in the northeast of the United States. Well, I stumbled across an article that was published in 1919 by Dr. Rubel. Now, Dr. Rubel was the medical director at the Boston New England Sanitarium. And what he wrote was, he said, this epidemic has given us a fine opportunity to see if there is a difference in terms of our therapies. He called this rational therapies. And so that's exactly what he set out to do. And what he did was collected the data from all of the 10 sanitariums that he knew about in the northeast of the United States and compared them to what was going on in the sanitariums or in the Army hospitals at the time. So what he did was basically say, which one is better? Is it the treatment in the Army hospitals with the aspirin where we're trying to kill the fever, or is it in the sanitariums where we're trying to basically increase the body temperature with hot towels and hot foot baths and things of that nature? And just a point, the things that they were doing in the sanitariums, there's nothing there that we couldn't do in our own homes today. I mean, we've got hot water, we've got all of these sorts of things. So he did that. And what he found was a couple of things. Number one, he found that there's two phases. There was the early phase and the late phase, just like we have with COVID. He's found the same thing with the flu. And the thing that demarcated that was exactly what we have with the COVID-19, and that is pneumonia. So the practice in the sanitarium was if anybody came down with any kind of symptoms, period, there's no need to test. You just immediately start hydrotherapy. You immediately start sunlight. You immediately start fresh air and bed rest. That was the key for the sanitariums. When they did that, and this was a number of about 446 subjects, only 2% of those subjects went on to develop pneumonia. Only 2%. He was able to get the data from the Army hospitals. And in the Army hospitals, about 20% of the camp came down with the flu. How many of those patients with the flu went on to develop pneumonia when they got aspirin and they got all of these other things? 16%. So 8 times the number of people in these Army hospitals had pneumonia. Now, when you looked at pneumonia in both the Army hospitals and the sanitariums, the mortality from there was about 40 to 50% in both. So it didn't matter. Once you had pneumonia, the damage had already been done. And so when you look at the infection fatality rate in the sanitariums, it was about 1.1%, whereas the infection fatality rate in the Army camps was about 6.4%. So it was a fraction of that. So obviously this is a different time, this is a different practice, this is a different disease, but it's the same immune system. And the very fact that hydrotherapy and heat can cause potentially an increase of the very thing that's lacking that we're seeing early on in the COVID-19 course gives me pause that there is biological plausibility that hydrotherapy early on, while you're supposed to be sitting home and waiting for you to get sick enough to go to the hospital, may impact and change the course of the disease so that you don't have to go to the hospital. The reason why I find this particularly attractive is because there's no company that has to make hydrotherapy. There's no rationing of hydrotherapy. You don't have to leave your home for hydrotherapy. You practicing hydrotherapy doesn't take away the ability from somebody else to do that. All of those things are the same problems, though, that you have with ivermectin or hydroxychloroquine or any other medication that might have to be produced and be distributed. This is something that everybody can do, and it's also got very, very low risk. So I think, and actually I am working currently with an institution up in Northern California called Weimar that is looking into this, and we actually done a pilot project with students on the campus to do hydrotherapy to see if it will. We're measuring we're measuring markers, we're measuring inflammatory. It's not a randomized controlled trial in any sense, but we're trying to get more data to see if this is a plausible way of dealing with this. And of course, this would not be affected by viral mutations or anything like that. It's a way of teaching the immune system or revving up or enhancing the immune system to deal with an infection that is suppressing the innate immune system. So I've said a lot there, but ask away, see what you think.
That is a really phenomenal scholarly work that you did there, Roger, diving deep into history, and that is just so informative, and I really enjoyed listening to all of that research that you dug into. Fascinating. I do have a few questions for you, and I hope I don't forget them all because there's quite a few that lined up. First of all, with the interferon response that occurs when you elevate the core body temperature, whether that's through a hot bath or a sauna or a steam shower, or perhaps even hot towels you were mentioning.
Yeah.
How long does that increased interferon response last? Is that something, for example, that's 24 hours, like you can still measure, or is it just very, very acute, or is it even known?
I don't know if it's known. I do know that in those sanitariums, it's very labor intensive. It's actually the reason why this went out of favor. I mean, you can imagine that here you have this practice of doing hydrotherapy, which is very labor intensive, and then you have the discovery of penicillin in 1928. You can just give a tablet. So because of its labor intensity, it was generally done maybe once a day. And so if it lasted 24 hours, then that was probably enough. The protocol that we're doing right now, where we're testing it out, is maybe 2 or 3 times a week. But it is very labor intensive. We don't know how long it would last.
In your protocol that you're doing, are you giving your students hot baths? Are they taking a hot bath? And if so, how hot, how long, and how much of their body is submerged under the water?
So this is a very good question. The protocols are based on the historical protocols that have been published, and you can actually find his book. It's called Rational Hydrotherapy. It's written by John Harvey Kellogg. It's about 1,000 pages long. It's a massive book. I think it's in Google Scholar. You've got to sort of find the book. But there's a number of resources if people are interested. And one of the really where this is practiced, and if you were to talk to me about a year ago, I wouldn't have known anything about it. I've researched it. But the body of information that has kept this alive are really the physiotherapists, or the physical therapists, we call them in the United States, because of hydrotherapy helping in physical ailments, muscles, things of that nature. And so they're the ones that have kept this information for a long time. And so the protocol that I'm going to tell you is based on what they have seen and what they have done and used. And typically what is this? Is you basically have the patient lie down on a surface. And there's various ways of doing it, but you can use towels that are wet, and you can heat them up either in a microwave or on a stove. But it's basically boiling hot water with a towel, and you basically sandwich that between other towels. You place it on their back, and you place it on their chest. So they're basically being sandwiched. They're the meat, and the bread is 2 very hot towels. And you also place a very cold towel on their head and on their neck. And what you're trying to do there is you're trying to heat up the body as much as you possibly can, and not heat up the thermostat, which is in the brain, which is going to sweat and try to get rid of that heat as much as possible. So what you have here is you've got peripheral vasodilation that occurs, trying to give off the heat, but actually what's happening is it's picking up the heat, heating up the core body temperature, and you do this for about 20 minutes. Now, those towels will not remain hot for 20 minutes, so sometimes you have to recycle them and have more ready to go. So you heat them up, you cover them up, and if they're sweating, then you know that you're doing what you need to be doing. At the end of this 20 minutes of heat, something we do that's kind of paradoxical, and is also probably the most uncomfortable portion of this treatment, is you then basically put a very ice-cold towel and replace the hot with an ice-cold towel, and you do friction rub. Basically, it's a friction is the best way to explain it. This is something that's come along for 100 years. They've done this. When we look at the data and we try to see why they would do this, we believe that this seems to work because the cold causes vasoconstriction and it locks the heat in. So after you're done, it's not easy for the heat to dissipate through those vasodilated vasculature. But the other thing that it does is just like we know when you take a cold shower, that vasoconstriction causes demargination of leukocytes. And that causes the amount of leukocytes in solution, if you will, or in the vasculature to go through, find the viral particles, and report to their lymph nodes through that increased circulation. And that sort of jump starts the innate immune system in finding those epitopes and presenting them to the antigen-presenting cells. After that's done, the protocol is for them to lie down and to really not move for the next hour and to just completely rest. And so this is what we're doing. And I don't believe any of the students. Now, this is a student population, so they're young. I wouldn't expect these patients to need to go to the hospital, and I don't believe that in any of our cohort they've progressed or gotten worse.
Do you measure their temperature? Is there a rectal thermometer in there somewhere?
Yeah, they're not doing rectal thermometers. We're currently measuring. We are measuring temperature. We're also measuring a number of cytokines as well in that. And we've just finished the preliminary aspects, so we haven't had a chance to look at the data as yet. But it'll be very interesting to see.
It's fascinating that you're adding the cold shock, and I don't know how much the friction plays a role, but because in Finland, where saunas are ubiquitous, it's also quite common to jump in a cold water, freezing, like the Baltic Sea or something. A lot of people are jumping into the cold water after their saunas, and they go back and forth as well.
It's funny you say that. How long has the human race been on this planet? We could debate that, but it's probably been at least thousands and thousands of years. And do we believe that we've only discovered immunity and what works in the last 100 years? I think not. I think a lot of learning has been passed down generation to generation, and probably in multiple cultures. And one thing that's really I found very interesting is no matter who I've talked to, and I've talked to a number of people that are interested in this, whether they are of Asian descent, whether they are of Middle Eastern descent, whether they are from South America, or as you mentioned, in Nordic countries, all of them seem to have this memory. Whether it's their grandmother that did it or whether they look back 100 years ago, they all seem to do the same thing. They come down with an illness, a virus, and for instance, in the Middle East, I was talking to someone from Iran. He said, my grandmother, when we got sick, they would put us the hot sands. They would use whatever was hot around them, and they would use it to improve their current situation, whether it was a viral infection or what have you. And I think there may be something there. Maybe we've forgotten what we needed to do. And what I'd like to say is this: is that here we are in this pandemic, and we don't have all the medications to treat all these patients. Instead of saying, you know what, you're just going to have to wait at home and wait for you to be sick enough to go to the hospital. That's kind of like turning back the clock thousands of years. Why don't we just turn back the clock 100 years and see what we did 100 years ago when we didn't have these things and see if they work? I 100% believe that we need to do randomized controlled trials to really see whether they work. I want to see if they work. But the question is in the meantime, while we're waiting for them to work, if there's something that has biological plausibility and it has very little risk, what's the risk of hydrotherapy? Well, number one, burning yourself. You have to be very careful you don't burn yourself. And number two, if you've got a predilection for cardiac arrhythmias or tachycardia or atrial fibrillation, it's probably not a wise thing to be exposing yourself to temperature extremes. So barring that, I think this has got pretty low risk and maybe beneficial.
So 100% agree with you. And, there have been quite a few studies looking at the health benefits of using the sauna. There's been a lot of observational studies from a friend of mine, Dr. Jari Laukkanen. He's an MD, PhD, and he is the senior author on the paper that showed men, I believe it was men and women, in that study that used the sauna 2 to 3 times a week had a 20% lower pneumonia risk, and then if they did 4 to 7 times a week, it was maybe up to 40% lower, something like that, where it was dose dependent, and they had corrected for a whole host of factors, all types of different respiratory diseases. They corrected for asthma, lipid levels, just many different things. And so that was something that was quite surprising to me, because I was so familiar with the literature on the benefits of using the sauna on cardiovascular health and how, heat stress itself, it is elevating your core body temperature. And in a way it's mimicking exercise. Your heart rate elevates. They've done a side-by-side head-to-head comparison on a stationary bicycle and comparing it to 20 minutes in a sauna. And all the same physiological changes happen while you're exercising. Your blood pressure actually goes up. Your heart rate goes up. You sweat. Your core body temperature elevates. While you're in the sauna, your blood pressure goes up while you're in there. Your heart rate goes up. You're sweating. Your core body temperature goes up. But then when you're done with the exercise or you're done with the sauna, blood pressure goes down even lower than baseline. Your heart rate improves, and so it's very comparable to cardiovascular exercise, and there's many benefits in terms of chronic sauna use, and I think to some degree hot baths, and perhaps this hydrotherapy, I think that falls in that category where you're elevating your core body temperature, whether it's through a hot bath or these hot towels, or if it's in a steam room or a sauna, which is what I have. I try to do it 4 times a week, but it's fascinating that could actually be helping my innate immune system. And I think there's other studies that have shown effects as well, like common cold.
Yep, that's exactly right. I mean, not just on cardiovascular, but also on immunity, and also on, like real world colds. So they've done multiple studies on these, and they've shown there to be a benefit in that. And so because it seems as though the benefit that we get from hydrotherapy or thermal hydrotherapy, however you want to call it, seems to be the one part of the immune system that's crippled early on with this coronavirus. There's biological plausibility again there that I think, wow, this piece seems to fit. The only thing we're missing here is a randomized controlled trial. Boy, somebody should do that. I mean, that would be amazing.
Yeah, absolutely. Do you take hot baths at home?
Yeah, so I have a spa outside. Actually, believe it or not, I live at about a mile up here in Southern California, so we've just got about 6 to 8 feet of snow. I'm looking out the window right now because we've got about, well, it's melting right now, but it's about 6 to 8 inches of snow. And so just the other day, we all went into our spa and heated that thing up to the max, and got out and ran around in the snow, rolled around in the snow, and then we jumped back in, and it was invigorating. So I do that every day. My wife is also an internist. She works at the hospital, and so every day we've made it a point that when we come home from work and we go through our rigmarole, where we basically disrobe in the garage and put the coronavirus in this basket, and that goes into that. We basically go directly to the spa, and hopefully the chlorine and the hot water kills the coronavirus. But even more importantly, hopefully, if we happen to be exposed that day and we just don't know it yet, that treatment in the sauna, or the spa, I should say, helps our innate immune system to find that virus and to kill that virus before it has a chance to do its dirty work.
Absolutely. I've been trying. My husband, he's been really big on getting in the jacuzzi and then hopping into the 56-degree pool. I'm having to adapt. Cold showers are a little easier for me, but they're not. I mean, although they're colder now, I was actually doing a lot of cold showers in the summer, so I've been doing that sauna, and the summertime is warmer. The cold shower is warmer, so it's not really as cold as it should be. So I'm trying to get into the cold a little bit more. What are your thoughts on, for example, like people that are getting vaccines? You've gotten the mRNA vaccine.
So I got the Pfizer vaccine probably a little over a week ago. And I didn't change what I was doing. I was still doing it. I don't think it would have an effect. The way that the mRNA is delivered to the cells so that they can make the protein is in these very small little micelles, or these bilipid layers that shouldn't have an effect. It shouldn't be immunogenic. So I don't think it should affect the efficacy of the vaccine.
Using the sauna or, yeah. Can you talk a little bit about, just briefly, I know we've been chatting a while, I promise to wrap it up, but mRNA vaccines are a new technology that's, I mean, they're not a new technology. They've definitely been around for a few years, but it's new to humans, having it, use in humans, basically.
Yeah, so if you think about mRNA vaccines, it's like an envelope with a message in it. And that message is going to tell the cell what kind of proteins to make. This is exactly what happens, by the way, when you get a viral infection. When you get coronavirus or any other coronavirus or any other RNA virus that comes along, is that virus fuses with your cell, whether it's in the cells in your nasal mucosa or anywhere else. And it basically tells those cells to make protein, to make foreign proteins. And so in that sense, this is no different. We're just doing it in a way that doesn't cause more viruses to be made. See, when you get infected with a virus, the virus tells the cells to make more of everything, make more RNA, make more viral proteins, so your cell can make more virus. In this sense, the mRNA vaccine is only telling your cell to make a portion of the protein which we want the immune system to recognize, so that if it ever comes around again, the immune system is ready to attack it and to prevent it from invading your body. So in that sense, this is like a sort of a deadened a virus that we're putting in, but it's not even that. It's not even a virus. It's just a portion of the mRNA. So what about mRNA? mRNA is in the cytoplasm of the cell. It's not in the nucleus of the cell. And if you can imagine, we had a professor on from San Diego, Dr. Crotty, who I love his analogy. It's like a Post-it note. mRNAs are like Post-it notes. They're here today, maybe a few days later, they're gone. You crumple it up and you throw it away. They are not like your marriage certificate or your Social Security card that you put away in a filing cabinet that you never take out, and it's like the original. That's like your DNA. That's like in the nucleus. So that is not what an mRNA is. An mRNA is like your scratch-it Post-it notes that you post in your room, and you're here today and gone tomorrow. So there's really not a danger that this mRNA is going to hang around. And even if it were to hang around, the purpose of the immune system is to find these cells with this foreign mRNA in it, because it makes proteins that are foreign, and to destroy those cells. That's why you get an immunogenic response when you get the flu vaccine, or in this case, the mRNA vaccine. You get pain at the site. You get a little bit of a fever, perhaps. You might have some muscle aches, body aches. It'll feel like you actually have a viral infection, because that's your interferon that's responding to it. That's your adaptive immune system eventually that's responding to it. So that would explain Moderna's vaccine and also Pfizer's vaccine. The other one that's coming out is the AstraZeneca Oxford one. Does very same thing, except instead of using mRNA in a little, like a lipid droplet, like a butter droplet, if you like, it's using a different vector. It's actually using a chimpanzee adenovirus. Now you're like, why would you use a chimpanzee adenovirus? Well, it's because humans haven't seen chimpanzee adenovirus. And so we don't want to have a vector used in that situation that can be recognized by the immune system and destroy the vector before the message gets into the cell. In this case, the message is not an mRNA, it's actually a DNA. And so the DNA goes in to the nucleus in the AstraZeneca Oxford version, where it is transcribed into an mRNA, and then the rest is the same from there. So that's basically the three types of vaccines currently available, except the Oxford one, I believe, was just approved a couple of days ago in Great Britain, so that'll be coming out. There's a whole bunch of other vaccinations, even sort of the conventional type where they actually have the protein and they inject that. Those are in process still. They have not come out. The reason why they're probably taking longer is because it takes a long time to make the protein, and there's a lot of regulation that goes along in making the protein. And that's why these vaccine companies who choose not to use mRNA, who choose to do the conventional way, are taking a long time. And that's why in the past it took a long time to make a vaccine because there's a lot of regulation that goes involved. There's a lot of making sure that everything is purified. What Moderna and what Pfizer and what AstraZeneca are doing is they're moving that factory production point out of their realm and they're putting it into your body. So it's your body that's now making the protein. It's your body that's doing this. They don't have to do that, and therefore they can get a product faster. And the other advantage with it, by the way, is we've talked about a little bit about these mutations or variants of the virus, and we're worried whether or not the immune system is going to be able to track this and actually be effective against it. Well, the nice thing about the information, the mRNA, is that if this mutation or if this variant is significant, they can always change the information on the mRNA so that it matches the variant, and so the immune system can respond to that. And they can do that actually fairly quickly. So these are all sort of interesting advances. I can completely understand how people would say, well, I don't know, this is kind of new, let's see how this works. That's a perfectly rational response to have to see, because obviously there's a lot of things that we don't know about, and we're not going to know about it until we actually immunize and vaccinate a large population of people. But so far, it seems to be very safe, and it seems to be effective.
In terms of with vaccines, there obviously are potential side effects that may or may not happen in an individual. I mean, you can go on the CDC website and look at the variety of vaccines and look at the potential side effects for a variety of vaccines that are available. Are those? It seems, at least looking at the list, that those side effects typically are acute. They're not a long-term thing that you're looking at, a year from now,
Correct.
all of a sudden appearing. Or is that something to worry about in general with vaccines? Has it ever really been documented?
Yeah. So there can be long-term effects that can happen. Generally speaking, though, 90% of those long-term effects usually pop up within the first month or two. And so we're going to know pretty quickly whether or not there's going to be long-term effects in the post-marketing. Probably the worst case scenario that we've seen so far was a flu vaccine that was it was a regular flu vaccine. It was not an mRNA, was not a DNA. It was just a regular flu vaccine that was administered in Europe a number of years ago. This is back in 2009, 2010. And they did find an increased risk of narcolepsy in patients that were vaccinated with that type of vaccine. And the thought process there is that perhaps there was an immune response that cross-reacted with the portion of the brain that produces hypocretin, which is the basis for narcolepsy. And so it didn't happen in all of those patients, but it was substantially increased in the general population. So those are the types of things that we would be looking for. It's usually an autoimmune response. But I would just say at this point that right now, what we're seeing in terms of COVID infections and vaccinations, your risk of getting a post-infective autoimmune condition is probably higher in COVID, if you were to get infected with COVID, versus getting the vaccine. Remember, you're going to make antibodies against multiple portions of the coronavirus. And so your chances of getting an antibody that might be directed against something in your body is higher when you have more epitopes, like you would with a natural infection with COVID-19, than you would against a very specific portion of a very specific protein of SARS-CoV-2, which is the spike protein. So, for instance, Guillain-Barré syndrome. It's very well known that people who come down with viral infections can get this thing called Guillain-Barré syndrome, which is an autoimmune condition where your antibodies attack your nerves. And you can't, it's sort of called an ascending paralysis, where you can't walk and first then you can't breathe. It's very rare, but it's definitely known to happen after a natural infection. Well, does it also happen after immunizations? Yes, it can. But we believe it's probably higher in a natural infection than it would be in an immunization. And when we're talking about a pandemic situation, we weigh the risks and the benefits, and I believe that the benefits of getting the vaccine outweigh the risks, at least at this point. given the information that we have.
I'm 100% with you, and I also am excited about this new mRNA technology that's
Yeah.
being used. As you mentioned, I think there are actually benefits to having this technology as well. So I'm actually excited that it's actually a new technology that we're using for vaccines. Are people with COVID-19? You read all these horror stories of, obviously there's the risk of being hospitalized and going to the ICU and needing oxygen and, progressing into this severe case. But there's a lot of people, as you mentioned, 80% of people that don't have to go to the hospital, that their immune system takes care of it. They don't have a real severe case. But then you start to read about these other long-term effects that are cropping up, like heart palpitations and all sorts of funny stuff.
So there's one study that showed that 60% a month out still had myocarditis or inflammation of heart tissue. That's pretty scary. What are the long-term effects that we're going to see from this pandemic? Because there's millions and millions that are being infected with this virus. And so even if it's just 1% of the people getting something, but we're seeing actually higher than that, that could really change the landscape in terms of what we see out there in terms of disease and population. So it's not this binary thing about they live, they died. It's they live, but they've got, and the term is long haulers, of course, and more people are becoming long haulers. Unfortunately, we don't know how long this stuff is going to last, but I've seen studies. One recent study that showed that one rare side effect was psychosis. People actually hearing things and seeing things. It's very rare, but it's certainly something that's well documented in people that have been completely healthy until they came down with the virus.
Wow. I'm certainly more afraid of long-term effects with getting COVID-19 versus getting a mRNA vaccine. Is this autoantibodies like that you mentioned, that is a common thing with getting any viral illness? Has that been looked at or studied or linked to this long-term?
So they're looking at this. We saw in kids there was this Kawasaki-like illness that was occurring. We just don't know if that's similar to what we're seeing. I anticipate that we're going to be doing a lot more research in terms of the immunity and post-immunity as we go.
Well, I am, for one, extremely excited about the vaccine, that has now been, making its way to the population. And I've really, really enjoyed this conversation, Roger. What are some of the top 5 things that you're doing in your lifestyle right now to keep yourself healthy and your friends and your family and perhaps patients? I'm not sure. Obviously, this is not medical advice. But what you're doing?
So I think probably one of the biggest things that I'm doing is making sure that I get enough sleep. That's number one. We talked about that. Number 2 is I am making sure that we're doing contrast showers. So what is a contrast shower? Hot and then cold, hot and then cold, hot and then cold. So 5 minutes hot, 1 minute cold, 5 minutes hot, or 3 minutes hot, 1 minute cold, and another 3 minutes hot, 1 minute cold. Hot as you can tolerate, as cold as you can tolerate. And as we get toward the winter months, cold becomes even colder. So those cold water in the pipes can really do it. So I do that. I'm also obviously taking supplement with vitamin D. That's probably one of the most important ones I'm doing. For others, there's not as much data on, but I'm still making sure I've got, I get a nice big bowl of every antioxidant fruit I can possibly get, blackberries, strawberries, raspberries, pineapple. That's what I have for breakfast. I'm also taking NAC and acetylcysteine. There's a study that showed that it improves symptoms in the flu virus. We don't know if it helps in COVID-19, but as we talked about earlier with ACE2 and the fact that there's oxidative stress, NAC is a great antioxidant. It's packed with antioxidants, and it recycles the glutathione peroxidase system, which is helpful in dealing with oxidative stress. So I'm taking that. I'm also taking zinc, but you want to make sure that you don't take too much zinc. 40 milligrams. You don't want to take more than 40 milligrams of zinc a day. That's elemental zinc. Otherwise, you can have copper. When you see a lot of people in the hospital dying and it could really weigh on you. You've got to have your faith placed in something higher than just yourself. And it's not just a matter of what macromolecules you can take into your system, but you've got to be grounded and know what you're doing.
Absolutely. Thank you so much, Roger, for this conversation, for your amazing coverage of the COVID-19 pandemic on your YouTube channel, MedCram Videos. Has been by far if I want to know about anything going on with COVID-19, I go to MedCram. I tell everyone about it. I mean, it's just been very scientific analysis, very well explained to people that don't have a science or medical background. Just phenomenal job with these videos on COVID-19. If people want to continue to find out more about what you're doing, where's the best places they can find you?
Yeah, so if they go to YouTube and just type in MedCram, go to our channel and sort the videos by chronology, they'll see the latest of what we're doing. MedCram.com and Facebook, and also Twitter. We tweet as well.
At MedCram Videos.
Yeah.
Great. So everything is at MedCram Videos, basically, on all the platforms: Instagram,
pretty much,
Twitter, Facebook, YouTube, and the website. All right, Roger. Well, thank you so much. I really appreciate everything that you've been doing, and continue and look forward to more information that you put out. And I just enjoyed this conversation a tremendous amount. So thank you. Make sure you guys subscribe to our YouTube channel. That way you get notified every time we release a new video. Also, make sure to check out Dr. Roger Seheult's channel, MedCram Videos. Catch you guys soon.